Welcome to EJB Talks, Rutgers Blaustein School experts in policy, planning, and health, where we talk with our faculty and staff experts, as well as students, about how the fields of public policy, urban planning, public health, health administration, and public and urban informatics affect your lives. Welcome to another episode of EJB Talks. I'm Stuart Shapiro, the Associate Dean of the Faculty at the Blaustein School, and the purpose of this podcast is to talk with my colleagues about issues affecting people in New Jersey, the United States, and the world. Today we return to healthcare amidst the COVID-19 crisis, and for the first time we're welcoming two guests. The first is my colleague, Professor Sumitra Bhuyan, who teaches in our health administration program here at the Blaustein School. We're also very lucky to have Dr. Sabiha Hussain from the ICU at Robert Wood Johnson Hospital. Sumitra, Sabiha, thanks for taking a few minutes to speak with us today.
Thank you.
Sumitra, can you tell us a little bit about your general area of research, your connection to these issues?
Hi, good morning, Stuart. Thank you for having us today. My research focuses on understanding how information technology can improve health outcomes with an overarching goal to improve the health of the population, both locally here in the United States and globally. I think we should better leverage health IT to make our healthcare system safer, improve accessibility, and reduce cost. We spend about 18% of our GDP on healthcare, but the health outcomes and the indicators do not reflect that investment. In Blaustein, I also teach graduate course on population health management.
Wonderful. And Dr. Hussain, can you tell us about your work at RWJ?
Yeah, I work here in the ICU at Robert Wood Johnson in New Brunswick. I also teach at the medical school, and I am medical school faculty. Recently, we've been dealing with this crisis, but prior to that, I've been doing a lot of work looking at social determinants of health in the ICU and how they relate to our ICU admissions. And I'm not that surprised with the disparity that we're seeing with this crisis because in the past we'd seen that a lot of our patients were actually having social determinants, and that most of the individuals who were being readmitted, 50% higher rate of readmissions of those patients who had social determinants. So, this crisis, I think, just brings that more to par. And I do agree with Sumitra when he says that we do have to leverage IT to help us better access these patients.
So you mentioned social determinants of health, and that's something we're big on in the Blaustein School because we have people that study policy, planning, health. We're very convinced that it's all one package. But can you explain for our audience what you mean by social determinants of health?
Well, social determinants of health are things that are outside your just like heart disease and other factors that affect your health, such as access to health care, being able to pay for medications, being able to get a ride to even go to see your physician, being able to pay your utility bills and have a refrigerator where you can actually keep your insulin, so that you can take that. So, a lot of factors that are sometimes not necessarily under your control, but they do impact your health. And we recognize that. I know we're sort of late to the game when it comes to actual providers thinking about this. We came to this game at around like 4 years ago, and when I talked to the social workers and our community partners, they're like, "What took you guys so long?" um, but I think that having these conversations, we realize like I was seeing patients keep coming back to the ICU, and we're like, we have to stop this. We can't just have them, we fix them and they come right back. There's something that we need that's bigger than us, that we need to be a part of. So that's what we started doing very early.
Great. And Sumitra, I know you've given some thought to this too, the role that disparities play and the fact that COVID 19 has really laid bare those disparities for everyone to see. Can you talk about your perspective on why we see that happening?
So let me piggyback on what Dr. Hussein just said. As a health services researcher, I'm studying this disparity for more than 12 years now. Although millions of Americans now, they're very surprised to see that the people of color have worse outcomes from COVID-19 and they're dying more as compared to other race and ethnicity. Sadly, those for us in public health and health policy world, and also in the medicine, that is actually our worst fear. It came true. This was a ticking bomb waiting to explode, and COVID 19 just exacerbated the existing disparity at a structural level in American society. And I'm going to basically touch base on a few things Dr. Hussein already mentioned. One thing is, Dr. Anthony Fauci, he said in one of the briefings about the chronic illnesses, right? The chronic illness is or disease is a risk factor for high COVID mortality, and a minority individual, specifically African American community, has uh, higher percentage of those chronic illnesses in that population. For example, hypertension, diabetes, etc. Um, and just giving you an example, the Trump administration repeatedly said that if you are not feeling well, first go and talk to your healthcare provider. But sadly, millions of Americans, they do not have any primary care provider to talk to. Specifically in the states that did not expand Medicaid, millions do not have access to any health insurance. Even in New Jersey, after expansion of Medicaid, about 8% of the state population do not have any insurance. So when we hear that they say that you go and talk to your doctor if you're not feeling well, most of the time I do not. Those people may not have a doctor to go and talk to, and most of the testing site do require some kind of doctor's prescription for testing. So there is also a concern that the people of the minority people or the people of color, they are less likely to get tested. And also, when someone has chronic illness, they need to have access to medication on time, and also have access to healthy food. Now, what is happening with millions of children at home? Some of these low-income families are using their SNAP fund to buy more food for more people, thus compromising on the quality and quantity of food. And maybe some people are also not spending money on medication, and they are buying food at this point because it's a time for survival. And current policies, according to the current policies, SNAP recipients cannot purchase the groceries online. So it also actually exposes a lot of low income minority people. They need to go to the grocery store to get those groceries, and thus exposing themselves to the virus more.
So my background is public policy. So the first question I ask whenever I hear this is, what can we do? What should we be doing differently? What lessons should we be learning? Obviously, things that you knew for a long time, but now everyone knows about these disparities. What can we do to alleviate them?
I think immediately what we need to do, we have some data about mortality, right? Some cities, some states are reporting that the African American, Hispanic, there's a higher mortality rate from COVID-19, but we also need the information for testing, right? So basically. Do we have testing sites in the minority communities, because they may not have reliable transportation to go to a far place to get tested, and when they are getting tested, that's another important question. New Jersey at this point is not releasing any data on race and ethnicity, uh, but I think that will be very important, not only race ethnicity data from the admission side of it, but also from the testing side. And I just got this data from the New Jersey State website yesterday. We actually had about 161,000 tests so far in New Jersey, and among that population, about 72,000 were tested positive. So that number is around 45%, which is still very high. And if you compare that number with countries like South Korea or Germany, those numbers were significantly lower, around 4% and 7% respectively. So I think there's a long way to go here to address and tackle COVID-19. We are now only testing those people who are at a higher risk. And I think the number needs to come down below 10%, uh, to before even we can think about going back to some kind of normal life that we had before the COVID-19.
Dr. Hussein, what kind of changes within the healthcare system can we make to deal with some of these disparity issues?
Yeah, I mean, I think it has to start from the very beginning, as Sumitra was trying to focus on, trying to have primary care be a real focus in these communities where, of course, as he was addressing the fact that individuals who have chronic diseases like hypertension and diabetes are the individuals who are in our ICUs dying. They're not the old elderly population that everybody was talking about. They're your young Hispanic males who unfortunately are a little bit overweight, have some hypertension, have some diabetes. So I think primary care is something that we really do need to focus in on, and sort of making access to that kind of care for this group something that's real and something that they can go to. And then also going on to make sure that we have a really strong public health system which allows for people to get medications, allows for them to be able to be followed in a meaningful manner. We are trying to follow these patients who are COVID positive out through our district clinics, and we're finding that it's really even hard to follow them because we don't actually know how to culturally do it. I don't think that we can just put it into one system fits all. A lot of people do not have access to good internet. They don't have access to computers, and we can't rely on reaching them in that way. We have to figure out in innovative ways. Maybe, as I was saying, like having kiosks at the grocery store so that they could potentially put in some of their data and be followed in that way. Also, I mean, testing is fine, but the issue becomes if you test positive, how can you expect these individuals to isolate? Like, they just don't have the means. A lot of them have to work. So there has to be something that's going on infrastructurally in the healthcare system that makes sure that these individuals who are very different in not just socioeconomics but also culturally, they are going to go to your laundry mats, right? And that's where they socialize. And so perhaps that's where we find them and follow them up. We're not able to necessarily just follow them up. They're not sitting at home waiting to answer their phones, and that's what we're finding. It's hard for us to follow them because we can't find them.
Right. There was a great op-ed in the Times this weekend about how we've allowed our public health infrastructure to degrade over the past 40 or 50 years, and now we're paying the price for it. You mentioned sort of people have to go to work. Sumitra, I know you've written about paid sick leave. Can you talk about why that's a component to dealing with some of these disparities?
Yes, I think the paid sick leave is a very important determinant to a lot of things, including access to timely care. And I believe, strongly believe, America need a permanent solution to this issue. The U.S. is the only country in the developed world without a federal mandate paid sick leave policy. We actually did a study before, and we found that the availability of paid sick leave resulted in significant less ED visits. And other studies also found that in terms of accessing primary care, preventative care, the people who have paid sick leave, they are more likely to do those kind of thing. Uh, and despite of that, millions of Americans, they actually do not have any paid sick leave. Actually, there was a study conducted from UC Berkeley in 2019 found that about 53% of the hourly service sector workers at 91 large American companies, they do not have access to any paid sick leave. And just giving you an example, it says that 78% of workers in McDonald's they surveyed access to no have no access to paid sick leave. And think about that. So for example, the McDonald's is now offering 14 days paid sick leave policies for the employees in their corporate stores, and about 95% of the McDonald's are franchisee owned. So even though they have some kind of policies in the corporate stores, those stores owned by the other franchises, the employees still do not have any provision of paid sick leave. So under the CARE Act the Trump administration signed recently, it mandate that organization or employers below 500 employees, they need to give paid sick leave if someone is sick for COVID-19, or some of the family member is sick from COVID-19. However, there is no provision for employers over 500 employees. It's important because a lot of these franchises are actually they have more than 500 the employees in the local franchises. And right now the policy on paper is that you either need to be tested positive for COVID-19, or the state or a company needs to put you in quarantine in order to be eligible for this paid sick leave. And we discussed about some of the obstacles or some of the issues with getting tested. We do not have enough testing. So it make extremely difficult for a low income individual, even they feel a little bit awkward or not feeling well, to skip their job, because by law they are still not, or by their regulation they're not still eligible for those paid sick leave policies. So I think, and also I believe we wasted a significant amount of time, at least at the beginning, at least a week or so, to actually navigate through this process, that what to do with the paid sick leave. And I think that time we could have better used to come up with our testing strategies rather than talking about paid sick leave. I think we need a permanent solution to this problem.
Yeah, by the time someone tests positive, it's really too late. They've probably infected a lot of other people at that point. Switching gears a bit, Sumitra, I know you've also written about telemedicine. I want to highlight that. And what is telemedicine, and why do you see its growth coming in the wake of the COVID-19 crisis?
So the whole concept of telemedicine has been here in the US for a while. This is not a new concept. So it is basically having access to a healthcare provider by means of video, audio, or any other virtual means. Uh, Even though it has been a part of the healthcare system for a long time, but there are significant regulations from our payer side, mainly the Medicare side of it, uh, for reimbursement for telemedicine services. And with this COVID-19, I think the CMS has discussed to actually lift some of those requirement and allowing providers to get reimbursed. I think that's a wonderful move, because that will reduce the burden on our healthcare workforce. People with minor medical symptoms, they should be able to access to the provider remotely. However, as Dr. Hussein mentioned, there is a digital divide in our society.
Right.
Uh, Individual from certain race and ethnic background, and even individuals in more rural areas, they do not have access to reliable internet. So that I think remain to be seen how this telemedicine service can be effective to empower those communities, minority communities, and the communities in the rural areas.
Yeah, my wife and kids had a remote appointment with their allergist this morning, and but we fall right in that category you're talking about. You know, we're upper middle class people. We have good internet access, and this was a minor issue, so it fits for that. But I do wonder how broadly it can be applied. Dr. Hussein, what do you think about the adequacy of care we can provide remotely?
I mean, I think, right now, as you can imagine, we're doing a lot of remote care. For patients, I do pulmonary critical care. So a lot of my patients, I really do need to listen to their lungs and be able to assess them in a meaningful manner. I mean, there is something to be said about, touching your patient.
Mm-hmm.
I think that is a very important concept where you do get when I walk into a patient's room, I can get a sense of the entire flavor of that patient within just that brief interaction, which you lose in telehealth. I think, but I think that it has its place. There are a lot of patients that cannot leave their house to come to see me because they're short of breath or whatever, and I could potentially do a meaningful short visit with them. So it has its role. I think that what it has done for us in it has allowed us to push forward with this. We've always wanted to be part of the whole telehealth um, scene, and it has moved the medical school to that in a much faster manner than we would have ever thought. And so we're all doing telehealth right now. I think it definitely has its place, but it of course doesn't fit every patient with every scenario.
Great. Well, I would be remiss if we wrap this up without getting a picture from you, Dr. Hussein, on what's life like on the front lines. I mean, I conduct these podcasts from the comfort of my home office and can talk about the policy stuff, but I think really our listeners would like to hear your experience and how things are going on the front lines and what you've seen this past month.
Yeah, I mean, I have to be honest. I've been doing this for 17 plus years, and I've never experienced anything like this.
Hmm.
I think that this is the disease process itself is very, very challenging and very daunting to us. I mean, we've seen a lot of patients. I've had patients, bleed out on me,
Oh,
die in front of my eyes. Those things have happened. But this disease process itself is um, it's so inclusive. It involves so many body systems that you're basically going down and rethinking your entire way that you've actually approached patients in the past. And I'm relying on unfortunately, a lot of the consultants are not here, right? There, a lot of them are actually at home, working from home. So you're relying on them to give you insight from there. Most of the critical care doctors are, of course, at the bedside taking care of these patients. And what I'm actually seeing is that there's a push, more of a surge in the ICU patient population, because now you're going into your like 4 week, 5 week mark of these patients, and those patients who are in the hospital who didn't get better within like a couple of days and were able to discharge, they're lagging, and now they're actually crashing and ending up in the unit. So
oh,
our unit numbers have actually picked up some in the past week or so.
wow.
And it has to do with the fact that they didn't get better and they're now sort of ending up in the ICU. I see this as a really long term. Unfortunately, we're going to be in this for a while, and the follow up act has to be as well as it was for the World Trade Center victims, where they had follow up and they still are being followed up in those clinics. I think that you're going to have that for these COVID-19 population. A subset of those populations who required oxygen and remain on oxygen, you're going to see some sequelae, either bronchiectasis or pulmonary hypertension. Um, a lot of these patients were sending home on blood thinners. So there has to be an infrastructure, and this may be the push to actually have a very good public health infrastructure that supports this entire healthcare system. I think this may be the thing that does it for us, but we have to do something.
Yeah, I certainly hope you're right about that. And I don't think we've really grappled with the long term implications of still dealing with COVID-19. We're so understandably wrapped up in the moment and the numbers of the moment and such. But I think you're absolutely right. This is a long term problem, and hopefully it motivates us to come up with long term solutions. Um, I'd like to thank you both for coming on the podcast today, Dr. Hussein. I'd like to add a special thanks to you for being a non-Blaustein guest, and of course for everything you are doing on the front lines of this crisis. Also, a thank you to our production team, Tamara Swedberg, Amy Cobb, and Karen Olson. We'll be back in a few days with another talk from another expert from the Blaustein School. Sumitra, Sabia, thank you very much.
Thanks so much.
Thank you, Stuart, so much. Take care.